Thanks for giving me this opportunity to speak today. I will be speaking about non-melanoma skin cancers of the head and neck specifically. Let's see. Oops, sorry. Next slide. So in terms of cancers, skin cancers of the head and neck, they are, more commonly seen in our geriatric population. And surgery still is an important part of the initial management in a lot of the skin cancers in the head and neck area. Obviously, there are other adjuvant or adjunct treatments that are also used in treatment, and those usually include radiation, chemotherapy, and monoclonal antibodies, and also very commonly these days, immune therapy in management of some of the skin cancers as well. So when we take a look at head and neck skin cancers, we basically put them in the category of melanoma versus non-melanoma skin cancers, because melanoma is really in its own category, and the management is in a lot of ways different than the other skin cancers that we encounter. In terms of non-melanoma skin cancers, we usually see basal cell carcinomas, squamous cell carcinomas, Merkel cell carcinoma, which Dr. Gimbel just spoke about as well, and then other rare cancers. In the category of other rare cancers, we usually divide them into skin appendage carcinomas, such as sebaceous carcinoma, or sarcomas, or another type of rare cancer that we see arising from the skin of the head and neck as well. And they can be things such as malignant fibrous histiocytoma, dermal fibrosarcoma, or again, coming from vessel origin or vascular tissue angiosarcoma is another one that we see as well. Now, in terms of a basal cell carcinoma, so we will just kind of go through each of the ones that we just mentioned and go into them into a little bit more detail. So basal cell carcinoma is the most common type of skin cancer that we see in the head and neck area. It is more common in men than women, and it is very common for it to happen in the head and neck region. Obviously, it can occur in other parts of the body as well. One thing about this cancer is that it doesn't have a high propensity for going to other parts of the body, so metastasizing to lymph nodes or other distant sites. So that is quite rare when it comes to this particular cancer. Basal cell, there are 5 different types of basal cell carcinoma: superficial, nodular, pigmented, basosquamous, and morphaic basal cell carcinomas. In terms of, what are the risk factors for getting basal cell carcinoma? Again, UV radiation is, probably right up there as being the biggest reason for that. History of ionizing radiation, arsenic exposure, patients who are chronically immune suppressed. So, again, our patients who have had solid organ transplantations, like liver transplant, kidney transplant, they're actually at higher risk of developing basal cell carcinoma. So they have a 10-fold increased risk of developing basal cell cancers. Other immune compromised patients with history of HIV and AIDS and other autoimmune diseases are also at higher risk of developing basal cell carcinoma, especially those that can be more aggressive. Again, the risk factors, UV rays are basically a big part of this. And obviously, the primary way to protect ourselves from that is, sunscreen, sun protective clothing. So basically, those sun protective measures are, again, a very important factor in basically being able to prevent this cancer as well. And basal cell carcinoma is a cancer that has a very high mutation rate. And I think that's something that we're going to touch base later on when it comes to treatment, how that can be potentially something that is beneficial as well when it comes to that. Now, what are, the risk factors for developing aggressive, basal cell carcinoma? So generally, a cancer that's greater than 2 centimeters tends to be behaving a little bit more aggressively. If it is a cancer that's in the H region of the face, those tend to be more aggressive as well. If it's one that has previously been excised, but not completely, if it is one that has been there for a long period of time, if on the pathology, when they do the biopsy, they see signs of perineural invasion or invading, small nerves in the skin, that's generally a more aggressive feature as well. And then some of the subtypes that we just briefly talked about, among those morpheoform and basosquamous cancers are more aggressive as well. So just kind of going, through the different types, nodular basal cell carcinoma is the most common subtype that we see. Usually it's just kind of those pearly dome shaped. They usually have some vascularity to the surface of them. The edges are kind of rolled, and they tend to be locally invasive to the surrounding structures. Superficial basal cell is basically more like scaly, dry, red plaques that are seen on the skin of the face and head and neck region, and they tend to be the less aggressive, subtype of basal cell carcinoma, and we do again see them in other parts of the body as well. Basosquamous cell, again, that tends to be, again, in a more aggressive category. And I think part of that is because it partly looks like basal cell and partly like squamous cell. And generally, if you take all comers, squamous cell cancer is considered more aggressive than basal cell carcinoma. Because it is a little bit more like squamous cell cancer, those have a higher tendency of wanting to go to other parts of the body or local regional lymph nodes in the head and neck area as well. The other one is pigmented basal cell. So that is a tricky one because, we do see it more commonly in dark-skinned individuals. The pigment of it comes, again, from melanin, the skin pigment. But the thing about this one is that, again, if you take a look at this, it could very well be melanoma as well, just because of the pigmentation. Sometimes it can be a little bit confusing to distinguish between the two, and really a biopsy would be the only way to be able to find that out for sure. And morpheic basal cell, that one is basically an area that almost has indistinct borders. It appears more pale, compared to the surrounding tissue. And just because of the way it is a little bit harder to control that surgically in terms of being able to get clean edges or margins around when it is excised. So it's recommended, when we do excise these, that we utilize what is called frozen section, meaning that at the time of the excision, we take healthy tissue, what looks like healthy tissue from the edges, send that to the pathologist, have them take a look at it, right then and there, just to make sure that things are clear. As that can be a little bit more of an issue. Now, in terms of, the next cancer we will talk about is squamous cell cancer. Again, that is more commonly seen in elderly males. Sun-exposed sites are a common area for developing that cancer. Actinic keratosis, solar keratosis, they can be precursor lesions to squamous cell carcinoma. The transformation rate is somewhere between, 5 to 20% over a 10 to 25 year period of time. So a lot of times when those AK or SK, lesions are noticed, the patients will have treatment with 5-FU to help reduce basically the number of these actinic keratosis, so hopefully reduce the risk of those then ultimately transforming into squamous cell carcinoma. And again, they can, as you can see in this picture, they can be red, they can be scaly. Sometimes they can be very ulcerated and crusty as well. And when they become larger lesions like that on the scalp, which we do actually see very frequently in our practice, they sometimes start developing an odor in them as well. And usually that is not from an infection in that area, but it's actually from some of the cancer cells in the center of that larger tumor, basically dying off and creating some of that. Same thing, again, UV radiation tends to be still the biggest risk factor for developing squamous cell cancers. If someone has had ionizing radiation, polycyclic aromatic hydrocarbons, so the individuals who are probably most exposed to that are firefighters. It's basically an occupational hazard for them. Arsenic exposure. Again, another thing is if somebody has a chronic wound in an area that's irritated, that's not healing, the cells in that area can sometimes transform and develop squamous cell cancers. And same thing with, as we discussed, patients who have had organ transplantation or immune compromised are at high risk for developing basal cell carcinomas, but they're also they have a 30-fold increased risk of developing squamous cell cancers. And from, our head and neck practice, I can tell you that those patients tend to present with very aggressive, rapidly growing forms of squamous cell cancer that can, in many cases, be very challenging to control and treat. Again, what are those kind of more high risk factors for high risk squamous cell cancer? Again, if we're having a lesion that's greater than 2 centimeters, if it's extending, beyond the surface of the skin to the deeper tissue, if on pathology they say that it appears to be poorly differentiated or invading into the small nerves, invading into the lymphovascular kind of the basically, again, kind of the vasculature in that area that is draining, that area of the skin. Areas that are the ear and the lip, those tend to be more aggressive areas. And they're also, just because of anatomic location, a little bit harder to treat as well. If somebody has had an incomplete excision, that is a risk factor as well. And then as we discussed, people who are immune compromised are certainly at higher risk of developing aggressive forms of squamous cell cancer. And for squamous cell cancer, it does have a much higher propensity to want to go to what we call local regional lymph nodes. Now, in the local regional lymph nodes, what are those in the head and neck area? So parotid gland is a common area. So that's the spit gland or the salivary gland on the side of the face. And then basically anywhere along the neck, from basically the angle of the jaw all the way to the clavicle, those are high risk areas for developing nodal metastatic disease. And 25 to 50% of patients who have lymph nodes in their parotid that have squamous cell cancer in them will also have some in their cervical chain that will also have cancer. Just kind of as we had discussed, again, these are some of those other factors that confer basically higher risk when it comes to the squamous cell cancers, the size being one of them, as well as of the depth of the cancer and invasion into the surrounding nerves. Now, the other cancer, and I know Dr. Gimbel has already spoken quite a bit about this one, so I won't probably go into a lot more detail, but again, it is Merkel cell carcinoma is a high-grade neuroendocrine malignancy of the skin. It has the highest case fatality rate among skin cancers. So again, as we have discussed already, it is a very aggressive cancer. And in the head and neck region, 50% of the cases of Merkel cell carcinoma do occur in the head and neck region. And again, our elderly male population is probably the highest number of patients that we see with Merkel cell carcinoma, patients usually over the age of 70. And risk factors, again, UV exposure is a risk factor for this, a big risk factor for this kind of cancer as well. Some environmental agents, and then Merkel cell polyomavirus, as we had already discussed as well. Now, I know Dr. Gimbel had mentioned, usually kind of present as these pinkish nodular areas, papular areas. So that's an example of a Merkel cell carcinoma that's close to the lip. And sometimes you can have multiple nodule areas. Another thing about this cancer, we already discussed that it has a high propensity for metastatic developing metastases, not just to the lymph nodes in the area, so cervical lymph nodes and the parotid, but also distant metastatic disease to the liver, bone, lungs, brain, and other parts of the skin. So when we see a patient basically with a non-melanoma skin cancer, really anyone that comes in with a concern for possible skin cancer, it is important, that we do a thorough physical examination to really evaluate, the areas, because again, sometimes, certain areas are harder to treat surgically, or as Dr. Walker had mentioned, sometimes doing surgery on those areas can actually cause more morbidity or poor cosmetic outcome for those patients. So we do want to make sure we have a good idea, a good physical exam when we first meet our patients to really come up with the best treatment option. So again, areas that are a little bit harder to treat surgically, without compromising function, preauricular area, periorbital area, the nose, the commissure, the lips, or really any area on the lips would be included in that. And obviously, if there's not good preoperative planning, sometimes, this would result in a surgery that might not be optimal for the patient. So we do want to make sure we have a good idea of what we need to do. Another thing that's part of our assessment is evaluating the cranial nerves. So those are, the various motor nerves, and then also some nerves, that provide sensation. One big one, in the head and neck area is we want to evaluate the facial nerve. So if there are, patients who have lesions, on their face, or those who might have developed, disease in their parotid gland. The important thing about the parotid gland is also, even though it's a spit gland, it is through that gland goes a nerve that provides movement basically to your entire face. So we want to get a good idea of the baseline function of that for our patients. And then other nerves that provide sensation to the head and neck area as well. And what we do want to do, again, as Dr. Gimbel had mentioned too, when we see our patients, we do an evaluation of their lymph nodes. So we do, feel the parotid gland, both sides, the cervical lymph nodes, to see if there are any areas that we can palpate any enlarged lymph nodes. So that's part of our physical exam and assessment when we see our patients. Now, I think the general rule is, we do need to perform biopsies for our patients to be able to get the right diagnosis and then the treatment. Now, the recommendation if it's a small lesion, then certainly, you have an opportunity to do basically an excisional biopsy, meaning you're taking a small margin of a few millimeters around that, you're excising the lesion and you're sending, the whole specimen to the pathologist. Now, if it is a larger lesion and we're unsure, which one of those we might be looking at, then, we do an incisional biopsy, meaning we basically go and take a small portion of that skin lesion that we see and send that to the pathologist. If there are any lymph nodes that we palpate that appear to be abnormal, then a lot of times, we do get imaging to get a better idea of the extent of those lymphatic disease and also kind of the anatomical relationships. But also, we usually do a fine needle aspiration biopsy of those lymph nodes. Now, imaging. What is the role of imaging, when we have patients that come in with non-melanoma skin cancers? Again, it's not something that is indicated routinely for cancers that are early stage or smaller cancers, but for those cancers that are large and appear very aggressive, the imaging is mandatory, and it's basically part of figuring out the staging for our patients and really coming up with the best treatment options for them. So as you can see, in this area, this is these are skin lesions of the scalp that has actually eroded through the bone of the skull, and they're invading into the brain, which is something that you might think is impossible for a skin cancer, but again, within our practice, something that we do see not uncommon cancers. And what imaging modalities do we use? A CT scan or CAT scan is a common one that we use with contrast. It's usually imaging study that can easily be obtained relatively quickly, and it does provide us a lot of good information. Again, if we have concern about bone erosion, that is, again, an excellent one to use as well. And now other imaging studies is MRI is another one. Again, if we're concerned that a tumor is going into the brain, tracking along nerves, that is a good way to look at that. Now, if there are patients where we're really mostly worried about, cervical lymph nodes, are they worrisome or not, then an ultrasound can sometimes be enough. And if we have, again, a very aggressive cancer, or we have a patient with Merkel cell cancer as part of their staging process, we usually complete that PET CT scan as well. Now, in terms of treating early stage non-melanoma skin cancers, surgery is definitely a very common treatment modality that is used. And in terms of, how widely, we go around those. So the surgery can, again, be multiple different ways. One is wide local excision, which is something that we usually perform in our practice. And then the other option, certainly for the early stage cancers, such as squamous cell and basal cell carcinoma, can also be Mohs surgery, which is done by our dermatology colleagues. Now, how widely do we want to go around a skin lesion, to hopefully have a good chance of clearing that? For squamous cell cancers, again, 4 millimeters for skin lesions that are less than 2 centimeters, and 6 millimeters for lesions that are more than 2 centimeters. And for basal cell, it's recommended that there's at least a 3 millimeter margin around the lesion. Now, other options, aside from surgery, for these early stage cancers, for squamous cell cancer, basal cell cancer, squamous cell cancer in situ, 5-FU cream, imiquimod cream is also other therapies that can be used in a successful fashion. Cryotherapy can also be used. Again, that a lot of times is actually done for by our dermatology colleagues. Now, here it says, for early stage cancer, it says vismodegib. So a lot of times, vismodegib, that it can be used for that, but the vast majority of the time, really the scenarios that we're using this are actually the larger basal cell carcinomas, and that's basically a form of immune therapy that can be used as well in treatment of basal cell carcinoma. Now, for more for larger cancers, usually at that point in time, we do an unblocked resection. So we do the little bit wider margins. For squamous cell cancer, we typically go at least a centimeter around that, around the area where the mass is. If there is any evidence of nodal involvement, we would actually dissect those nodal basins as well. And a lot of times, these patients will also require other treatments such as radiotherapy as well. Now, I would say another thing that has been very exciting, I think, in the treatment of the skin cancer, especially locally advanced skin cancers, squamous cell cancer, being probably the most prominent one, is actually what we call neoadjuvant or treatment upfront with immune therapy agents. And the biggest one, that we utilize is semiplimab or Libtayo. And the response rate with that, again, the bigger studies have quoted around 47 to 50%. And, in our cohort of patients, I think we have patients where that almost near complete response is at an even higher rate. And that has been very exciting because it basically allows those patients with those very large squamous cell cancers, for example, on their face or on their scalp, to actually allow significant reduction to the size of these tumors, to the point where when we do then go ahead to consolidate their treatment after, they've had this impressive response, either with radiation therapy or a surgery that is hopefully much smaller than the surgery they would have needed initially. So I think that is a very exciting area. There are some more studies that are going to be done in this area as well. So that is definitely an area that's very exciting, near and dear to our hearts. For advanced basal cell carcinomas, again, vismodegib or hedgehog inhibitors are used commonly. That again allows those patients to hopefully just shrink the size of those tumors very significantly, kind of contain the disease, where then we can consolidate that with additional treatments such as surgery and radiation to hopefully get rid of those very large cancers without causing significant cosmetic deformity to the patient. And in patients who are resistant to vismodegib, semiplimab, which is used in squamous cell cancer, can also be utilized for those patients as well as a second line. Now, when we do remove basically cancers, sometimes, these cancers can be closed. These sites where we remove them, if they're small enough, they can be closed on their own. So that's called a primary repair. But other times we might need to utilize other things such as skin grafts, full thickness or split thickness skin graft. Sometimes we do local regional flaps, meaning we rotate some of the surrounding tissue to basically cover, those areas. In rare cases, when we do have very large areas that we are resecting, we would require what is called a free flap. So that is a free tissue transfer, meaning we're bringing tissue from another part of the body, like the arm, like the leg, or sometimes the back, and we're bringing that tissue with its own blood supply and hooking it up to blood supplies nearby to basically rebuild that area that has been removed as a result of surgery. And I think Merkel cell carcinoma, I would just briefly touch base with that when it comes in the head and neck, in the head and neck area, again, because it's an area where there's a lot of real estate in a very small region, the eyes, the nose, the lips, a lot of times, in the head and neck area, we typically go for 1 centimeter margins around the primary tumor. And the vast majority of time, again, in those early stages, we are still also performing sentinel lymph node biopsy when it comes to the Merkel cell carcinomas. And the head and neck area, head and neck itself is considered a higher risk. So, unless, these are, again, very, very small lesions, it is not uncommon for us to also consider radiation therapy for the patients after surgery as well. Thank you.